morning. I would like to present a study we did in Tel Aviv Medical Center regarding geometry of aortoventricular annulus and the need for pacemaker implantation following TAVI. As you all know, aortoventricular annulus is not perfectly round-shaped, it is often an oval shape. There is little data regarding AV annulus eccentricity and TAVI, but a small study shown that may be associated with increased rates of paravalvular leak. On the other hand, another study showed same TAVI success and safety outcomes in patients with oval annulus. And as you are aware, the conduction system is adjacent to aortoventricular annulus. Actually, his bundle pierces the central fibrous body and splits to left and right bundle exactly at the plane of the aortoventricular annulus. Postmortem studies show that mural tension causes disruption of connection of the conduction tissue. There's actually microhemorrhages inside his bundle and left bundle, and that shows it's not a simple inflammatory edematous process, and it's maybe irreversible. Known predictors of conduction abnormalities in TAVI patients include age, gender, prior right bundle branch block, type of prosthetic valve implanted, depth of implantation. As a group from Netherlands showed that implantation of aortic valve forces the aortoventricular annulus to a more circular shape. This gives us a clue about the forces acting on this structure. Our hypothesis was that more oval annulus will produce more mural tension on the shorter axis during prosthetic valve implantation, and this in turn will cause higher risk of conduction tissue disruption. So we retrospectively analyzed 123 consecutive patients. Aortoventricular annulus was analyzed by cardiac CT angiography. We measured ellipticity with help of elliptic factor, which is a difference of maximal and minimal diameters. We thought this is more straightforward index of ellipticity. We did univariate analysis and multivariate model adjusted for age, gender, prior right bundle branch block, type of prosthetic valve implanted, and depth of implantation. The mean age in our cohort was 82 years old. Most patients were implanted with the Medtronic call valve system. And out of 123 patients, 14 patients required implantation of a pacemaker. Indications for the implantations were a complete AV block in 8 patients, high degree AV block in 3 patients, and the RBBB with prolonged PR interval. These patients were taken into EP lab, and we measured the infranodal conduction abnormality during electrophysiological study. This is our institutional protocol. The mean maximal diameter was 25.8 millimeters, and the mean minimal diameter was 20.8 millimeters, which resulted in an elliptic factor of 5. Patients who required pacemaker had a much higher mean elliptic factor of 5.9, and patients who didn't require a pacemaker implantation had lower elliptic factor of 4.9. This was statistically significant in univariate and multivariate analysis. Also, if we take a cutoff of elliptic factor of 5, patients with below elliptic factor of 5, out of 48 patients, only 1 patient required the implantation of pacemaker. Patients with elliptic factor of more than 5, out of 75 patients, 13 patients required implantation of the pacemaker. Here is the example. On the panel A, you see in a CT scan of a 89 years old female without prior conduction abnormalities. Her maximal diameter was 28 millimeters. Her minimal diameter was 22 millimeters, which resulted in an elliptic factor of 6. On the day 3 after implantation of the aortic valve, prosthetic aortic valve, she developed a new left bundle branch block and prolonged PR interval. She was taken into electrophysiology lab, and the infranodal conduction abnormality was demonstrated, and she was subsequently implanted with permanent pacemaker. On the panel B, you see 83-year-old male with the annulus measuring 23 millimeters on the maximal diameter, 21 millimeters on the minimal diameter, which resulted in an elliptic factor of only 2, and he did not have any conduction abnormality during 1 year follow-up.
Yeah.
Limitation of our trial, first of all, we have multiple types of prosthetic valves implanted in our cohorts, but our cohort was done before the newer valve generation, Evolute R and Sapien S3, entered the practice. And we had relatively low rate of pacemaker implantation, which can be explained first by experience gained by the operator prior to the beginning of the cohort. He implanted more than 400 implantations. And we have also a unique institutional protocol where patients with new left bundle branch block, we take them into the electrophysiology lab and we see if there is an infranodal conduction defect. So to conclude, elliptic factor is an independent and significant predictor of need for pacemaker implantation after TAVI. A more elliptic annulus confers higher risk of conduction abnormalities, and it also underlines the importance of cardiac imaging, especially CT in TAVI. Thank you.